So today we heard three very interesting case scenarios about different aspects associated with CAR-T cell therapy. The first was looking at a syndrome known as HLH, or macrophage activation syndrome, in a patient who received treatment for ALL with CAR-T cells directed to CD19. Now, I think the learning points really for the community is to try and distinguish what macrophage activation syndromes and HLH is, because this can sometimes be very difficult to ascertain in the context of a patient who has significant cytokine release syndrome. But I think what is important is that you need to be proactive with the management of cytokine release syndrome. This patient had quite significant grade 2, grade 3 CRS, which then moved into HLH and macrophage activation syndrome. What was also very interesting here is that they used high-dose corticosteroids, which people are very concerned about with CAR-T cell therapy. But what was very clear was that there was persistence of the CAR-T product, and there was good memory CAR-T cells being shown on flow cytometry. And so I think it's very important to give these corticosteroids because it salvaged the patient out of the ICU and the patient was able to continue. There was also good use of tocilizumab and anakinra, which was vital to manage these cases. Now, the second case was a patient with mantle cell lymphoma, which is treated with a CD19 CAR-T cell therapy, and interestingly developed recurrent ICANS. Now, again, this is important to know because I think what happened in this case was that the first ICANS episode didn't fully resolve, and so we had relapse of the second ICANS episode. And then weirdly, we got this aseptic meningitis condition that happened afterwards, which is what we think is a pro-inflammatory state following the CAR-T cell product. Again, I think the take-home messages are early intervention with corticosteroids. Dexamethasone 10 milligrams 3 times a day is what you would give. In this case, the patient was escalated into methylprednisolone. One of the curious things that I draw parallels through into the myeloma sphere is that we do see neurotoxicities occurring with cilta-cel, for example, with cranial nerve palsies. And really the way to manage that is with chemotherapy such as cyclophosphamide. And we had a bit of a debate about whether we should be using chemotherapy. And what some people are saying is we don't want to use chemotherapy because you don't want to kill the CAR-T cells, but also you need to reduce the ICANS. So that's something that you need to think about very carefully. And then the last case in multiple myeloma was the use of NK cells, and was using cord blood derived allogeneic NK cells coupled with an NK CAR-T cell. What was interesting here was that the patient appeared to have a transient response. There was an expansion of the NK cells, but unfortunately there was no persistence and the patient relapsed. Now, this is one of the problems with NK cell therapy, particularly allogeneic NK cells, is that there is a lack of persistence with the product. And I think we need to do a little bit more work to try and understand how to do that. Certainly one of the questions was about giving cytokines to try and stimulate the NK cells, and I think that was lacking from this. And what was also interesting was that there was no CRS and ICANS, which is again of interest. But to my mind, I'm not convinced where NK cells sit with multiple myeloma therapy. My colleague Carlos suggested that perhaps this was more of use in an early consolidation prior to maintenance, and maybe that's where this would sit. But certainly a lot more work is required for NK cell therapy.